My name is Tess Taylor, and I'm a specialist with the Community Education Department at MDA. We're thrilled to have you join us today for our Women's Health and Neuromuscular Disease webinar. This learning event is part of our larger MDA Community Education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the Community Education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to the website for on-demand viewing at a later date. Everyone who's registered for today's session will receive that information in their inbox. Please know that all phone lines have been muted, but you can still ask questions. We will have a Q&A session at the end of Dr. Thornburg's presentation today. So if you are logged in live, you can use the chat or Q&A feature webinar to type in your questions. As a reminder, we're trying to stick to a little more general questions. So if you have a super specific question, you might want to reach out to our resource center for more information on that. MDA would like to thank our program sponsor, Regeneron Pharmaceuticals, for partnering with us on today's webinar. For over 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. To learn more about MDA, including a complete listing of all our programming, please visit mda.org. And now it is my pleasure to introduce our speaker today, Dr. Loralei Thornburg, MD, she, her. Dr. Thornburg is the James R. Woods Jr. Professional Obstetrics and Gynecology and Division Director of Maternal Fetal Medicine at the University of Rochester Medical Center in Rochester, New York, where she completed her residency and fellowship. She is passionate about the care of people with complex disease and pregnancy, most notably focused on neurologic and cardiac disease in pregnancy. She works with a number of organizations around the country to help birthing people have access to care they need to have safe and healthy reproductive lives, including during labor and delivery. So hi, Dr. Thornburg. Thank you so much for being here today. We're very excited about your presentation. And so I will turn the time over to you.
Great. Thank you so much for having me. I'm in Rochester, New York. I was up all night delivering babies, so if I make a misstatement, I don't mean to. You can see that I am in my office at home. It is full of thrifted things because that is my other thing that I like to do. And I hope that if you have questions, please put them in the chat. I have it open to my side here, and I will try to just keep an eye on it as we go. If things come up, things I can clarify as we go along. So if something's not clear, please say so. Both my dogs are in the room with me, so if they bark, I preemptively apologize. Okay, so I'm gonna do my best to, I'm gonna just share my, if I can do it correctly, I'm gonna just share my slides here, just so that we don't have any missteps. Okay, so can you see my slides? Yes?
Yes, that looks great. Thank you.
Perfect. No problem. All right. So in disclosures, I do have a book on neuromuscular disease and neuro diseases in pregnancy. I could theoretically get royalties from that. But just very theoretical, as they say. Let's see. There we go. Okay. The other thing is that I am not anyone who can be scared by any question. So if there's something you want to ask, if there is something that has been burning at your mind and you've been afraid to ask your doctor or afraid to ask someone at in the medical community, you really can't scare me. I have heard it all. I have seen it all. Don't worry. I'm boarded in 3 things: OBGYN, maternal fetal medicine, and family planning. So I really run the gambit of things that people do in their reproductive lives. And there really is no off-limits topic. So please ask me. I assure you, I have heard it all before. So I'm going to use women a lot in my slides. I'm going to try not to use it as much as I can, but when I do say women, it is to be specific that I'm speaking for assigned female at birth people that were in the study. It doesn't mean that I'm assuming anything about people's gender identity, and I'm trying to distinguish all gender data for neuromuscular disease from those that was specific to people assigned female at birth. So if I do use woman or shorthand, that is a shorthand simply for gender specific data. Okay. So we're going to try to, and this says DM, but I actually changed this slide set. It's going to be for basically all neuromuscular disease. We're going to talk about some preconception things. We're going to talk about family building, and we're going to talk about challenges around obstetrics. We're also going to talk about menopause. We're going to talk about general GYN care. So just to keep in mind that every single one of you is the expert on yourself. Pregnancy is often excluded from many, many trials. Even in mouse trials, which I just learned recently, they often just use male mice to try to eliminate any gender differences in how different drugs affect the knockout mice or things like that. So we really have very limited data on how hormones actually play into many neuromuscular diseases. And this is becoming increasingly clear. Sorry, I think I'm unmuted now. You can hear me. So we're seeing a lot more data starting to come out, people saying, hey, wait a second, I think there are gender differences in how these things are seen. And there are certain diseases where, they were assumed to be only affect men, but it turns out they affect women. They just affect people differently. I am going to talk a little bit about the menstrual cycle to some degree, probably not as much as you're thinking, more about menstrual care. And then there are data coming out now about how menstrual cycles affect people differently during different neuromuscular challenges. So often the neuromuscular data that we see, especially as OBGYNs, is lumped rather than disease specific. It'll be like people with a neuromuscular disorder. And obviously, we all know that that runs a very wide gambit. And so we do need to be very thoughtful about that the data may be very limited or may actually overrepresent or underrepresent different people. And disease-specific manifestations can drive many outcomes in specific plannings. So, if two different people have, for example, myotonic dystrophy, if one has lung manifestations and one does not, you can imagine that that's going to be very different in how we're going to address their pregnancy care. So just to be very clear, the summary of that slide was, we don't have a ton of data. Okay, so the obstetrics data that I want to talk about is basically three things. Do you want to make a family? No. Great. Let's talk about how to help make sure that pregnancy is a concern, and let's help you get healthy gender-specific care that can include enjoying sexuality if you want to. Yes, you want to make a family? Great. Let's do that. Let's talk about the safest way to do that. And then not sure? Let's talk about what family building and parenting can look like for people who have different kind of disorders. Again, I forgot to change this slide too, but I want to make sure that this is probably everybody knows this is the hill I'm probably going to die on. Access to sex ed and contraceptive education is a part of the life course of people. We need to not infantilize people with neuromuscular disorders. And I spend a lot of time talking to my colleagues in neurology and other specialties about this. And if you have a pregnant person with a neuromuscular disorder or any other neuro disease, basically, this is the question that I want people to be consistently asking. And this is the question you should ask your doctor. What would we do for this if I were not pregnant or my partner were not pregnant? And if they say, well, we would do this, let's start from a place of therapeutic excellence, not from a place of, oh my God, they're pregnant, we can't do anything else. So people with chronic disabilities are very underscreened for gender-specific care. And so if we look at cancer screenings and then routine prevention, we can see that people who have disabilities are underscreened. They're underscreened for mammography, they're underscreened for PAPs, they're underscreened for prostate exams. Influenza vaccines are slightly overdone. Pneumococcals are slightly overdone, and blood pressure readings are slightly overdone. So they're showing up to doctors more, but they're not getting gender-specific care for their community, probably because people are uncomfortable. And despite the fact that 60% of health professionals believe that sexual difficulties and sexual differences should be addressed, only about 6% of health professionals initiate these discussions on a frequent basis. Why? Well, because healthcare professionals are uncomfortable, right? There are not too many people who are willing to jump on a webinar or come into a room and engage with teenagers or people around like, so how's your sex life, right? That's not a thing that we just like bring up at cocktail parties. And so it can be uncomfortable for people to talk about that. There is a distinct lack of training around sexuality and sexuality as a portion of the normal adult experience, regardless of other medical conditions. And it's a subject that isn't addressed by other healthcare providers. And the patient doesn't bring it up, the healthcare provider doesn't bring it up, and kind of healthcare providers have this idea that someone else should be doing it, right? Like neurology thinks OBGYN should be doing it. OBGYN thinks like, well, I don't know if there are specific things they need. I don't know those things. And so nobody does it. And then often there's an absence of a sexologist on a healthcare team, because I did not know that was a job when I was looking at specialties, but there is. And then there's also the fear of opening Pandora's box, right? Because if somebody asks about these kind of questions, you have to be prepared with an answer, right? Or if you ask, how's your sex life? And somebody says it's terrible and I need help, and you have no resources and no training in that area, it can be very overwhelming. So if you ask somebody, like, or if you want to make a family, as doctors, we need to be prepared for the answer. If the answer is nope, then we need to be able to talk about contraception, healthy sexuality. And so I'm bringing this up because there's a new term that we call starting to have sex, okay? And we call it now sexual debut, which I like very much. I think it is a much better term than, losing one's virginity, like somehow like you like misplaced your keys. It's in starting to engage in adult sexuality in a healthy way. And so when we ask physicians when they first start talking about sex and sexuality, pediatrics, about 60% start at 14 and 90% start at 16. When we look at people with disabilities, only about 20% of people with disabilities have received any contraceptive counseling between the ages of 15 and 24. Peds neurology, only 11% of visits address this for teens with epilepsy. And I'm using epilepsy just because it's so much more common, and it's something that people are often on medications with profound effects both on their contraceptive method and on their pregnancy. And then if we look at adult congenital heart disease, which again, you can just imagine has a big effect on pregnancy, only less than 5% of teens in that 14 to 18-year-old recall any conversation about contraceptive counseling. However, when we look at sexual debut or age of first intercourse for women or people who were assigned sex at birth, women, we find that by 16 years old, half of American women are having sex or have had sex. So we are seeing that if you're not talking about this, and some of these going up to 24, you have missed the boat, right? Those people have already begun to engage in sexual activity, and you have not done your due diligence to be able to help. And we don't talk about contraception outside of the OB/GYN practice. And so bringing this up with your doctor and talking about it as a normal part of, you're putting me on this new medication. Is it going to affect my contraception? Is it going to affect my sexuality? Is it going to affect my ability to orgasm? Is it going to change my menstrual cycle? These are important questions, and they're things that doctors should understand. Additionally, if you are starting on a medication, it may be worth saying, is this medication something I need to be on contraception for? Is this a medication that could be dangerous during pregnancy? Not that I'm planning pregnancy, but I'm also, at risk for pregnancy because of the type of sex that I engage in. And so when we find that people under offer contraception in general, but they very much under offer contraception to people who have physical or intellectual or developmental disabilities. And that's a serious issue because people with all of these things have sex at about the same rate as people who don't. They also offer different types of contraception. And so they tend to offer things that are more in the medical world of IUDs, birth control pills, contraceptive implants, and they tend to offer less things in the things that they think of as more user intensive, things like shots and injections, things like vaginal rings, things like that. So and they tend to over offer sterilization, which I do not think is appropriate. So just keep that in mind that, is this the best contraception for me, or is this just what you're kind of knee jerk offering me because of what's going on? So when you choose contraception, remember that contraception is better for more than just baby prevention. It's really good for cycle control. It's really good for hormonal suppression. It's great for, it can be used as a hormone replacement when you're in that perimenopausal age. If you have heavy periods or weight issues, that can also be important. Keep in mind that migraines may affect the type of contraception you can take. Clotting history, if you're breastfeeding, if you have an STD risk because of the type of sex that you engage in, and what is your timeline for future pregnancy may affect what you want to do. And so when we think about people who've had complicated medical diseases, we have this whole big chart. It's blue and why am I saying blue? It's green and red, which is ironic that they picked it since red-green colorblind is a thing in the population, but whatever, I didn't pick the colors. So you can see that it's coded from 1 meaning safe for basically everybody to 4 meaning really shouldn't be used or used with extreme caution. And it has a lot of disorders on this big chart that your doctor can go to. Neuromuscular is not one of them. So unfortunately, we are in a little bit of a land without data. Contraception also be great for cycle and menstrual suppression. So a monthly period is not healthy, nor is it a requirement for health. You are not required to have a period every month just because you have to, just because you're a woman. And that isn't to be said that people, for example, who have polycystic ovary or who have menstrual challenges from hormonal disorders, they should be having some suppression or some progesterone exposure to prevent uterine cancer. But once you're on suppression, you don't need a period every month to be healthy. And we know that about 75% of people, even more so in people with neuromuscular, this information is starting to come out, especially some of the myotonic versions, have a lot of discomfort during their periods. They have a lot of challenges with their periods. They can have very heavy periods or a lot of pain with them. And so it may be more of a benefit for the whole person over just, oh, it's just contraception. No, it can be far more than that. We also know that PMS or menstrual things can also affect the GI system, and there are many neuromuscular diseases that have GI effects, so that can be an important thing too. Additionally, external menstrual care can be an extreme challenge in patients who have immobility. And so when we're thinking about asking about contraception, even if you're not sexually active, even if you're asking about it for your child, I don't know how many parents or people who help a family member or a partner take care of themselves, remembering that menstrual care can be really a challenge in immobility, and to skip that period may be helpful for everyone involved. So again, when we talk about doctors lacking training in these places, doctors are extremely not confident in talking about sexuality and healthcare for women-specific physical and other challenges. Periods are rarely talked about and rarely studied, as I've mentioned before. But I think it's important to note that menstrual care is cited in the literature as a task with a high degree of caregiver discomfort. And this can be one where people can find that they're having challenges with nursing help or with people helping them with caregiving at this time. This is a time when people lose caregivers, when their children start to transition into teenagehood, even for male appearing or male presenting people, or for people who were assigned male at birth. things like erections can be very uncomfortable for caregivers. So these are all tasks that can make things difficult. Both menstruation and disability, as we all know, are very highly stigmatized, and the combination may make it very difficult for some patients and families to discuss nursing help and nursing aid with. And so we'll have patients who have skin breakdown and things from menstrual uses. Just keeping in mind that, the real MVP of um, uh, um, the real MVP of contraception is IUDs. It is the most common contraception of female physicians. I don't know who besides me is old enough on here to remember the Ron Popeil set it and forget it, right? That's the IUD. You put it in, yes, it's uncomfortable to get in, but it has a very low risk profile, has a very high risk safety profile, and it's a 1 in that medical eligibility chart that I showed you for basically every medical condition. It can be placed with limited mobility, but you may need somebody who is trained in family planning, for example, to help with placement, because they often will be able to do office pain control. Some places offer oral pain medicines beforehand or other positioning help. And we're going to talk about GYN care a little bit too. So with IUDs, about 50% will be suppressed by a year. Implants, that's 30% by a year. Depo, you get to 65% suppression by 2 years. Contraceptive rings, you can space out the periods to only 3 or 4 times a year if you want, and you can actually do a complete suppression of your whole menstrual access. But that is not ideal because it does lead to bone loss and hot flashes. That's like an artificial menopause. But if you have somebody who's really struggling for a specific reason, like leading into surgery or things like that, that can sometimes be an option. This is an actual bathroom in Norway that when my daughter and I were there, and I was just thinking, like, I barely fit in this bathroom. How is this possibly the handicapped accessible bathroom? It was ridiculous. And so when we talk to women with disabilities, pad position, absorption, catheters, and urinary management, and then the combination of those things is cited as an area where people really struggle, including high limited access to facilities and the high cost of supplies. There are a lot of amazing websites out there with a lot of great information on new technologies that are available, things like menstrual underwear, which are great even for leakage, which we'll get to in a little bit, and menstrual cups. And there are so many better options than when I was young. Okay, if you're done having kids and you're just done with periods, this is only for people who are done with childbearing and healthy enough for surgery. Hysterectomy can get rid of any risk of having periods, as well as reduce or eliminate risks of other types of female-specific cancers. And, the recoveries now, most people go home the same day because they're done minimally invasively. And then endometrial ablation is an option for those who don't want to go all the way to hysterectomy or aren't healthy enough for that kind of surgery, where basically you use a balloon and you fill it with very hot water, and it destroys the internal lining of the uterus and stops the periods. So the hormones are still there, but the lining of the uterus no longer grows and shrinks each month because those cells have been destroyed by that process. When we think about menstrual management, this is going to be the same as incontinence management. So when I had my kids, and I'm sure there are people on here who remember this, they would give you these like mesh underwear with these giant pads that like were basically like 7 feet long, that you would put in this big pair of mesh underwear. Now, most hospitals are actually offering you an incontinence diaper, and they work amazing, right? It helps, like, you don't get stuff up your back, you don't get stuff through the front, you don't leak through the sides, and actually that can be great. And so people with heavy flow or change in sitting positions, I actually recommend you think about incontinence diapers for a menstrual supply. Skincare is critical. Anytime you have wetness on that very sensitive skin, you want to think about what you're going to do to protect it. So frequent pad or barrier changes, dry times if possible. So free bleeding is actually a great technique. So, a big Chucks pad or a big, pink pad or something absorbent underneath person, and then just allowing them to have their legs spread and allow the bleeding to just come out and not have a pad or anything there, so that you're getting the minimal amount of it sitting on the skin. Barrier cream is more than just for those cute little people, and I've taken the brand names off of these, but I think everybody knows what they are. They're basically all thick emollient diaper rashes. There's the zinc oxide versions, there's the yellow version, and then there's kind of the clear version. And I'm sure you recognize the containers, but they are all amazing. Avoid any of those with steroids, and those will really help to protect the skin from sitting in the wet. Okay. Every single office should be able to do care of the genitalia, but tips for making this the best: first thing in the morning, first visit after lunch. Those are going to be the times when you're least likely to have the staff be behind, and you're going to have the most staff available. Let the team know ahead what you need. Yes, they should be able to help you, but telling them ahead would be great. I'm going to need extra time. I'm bringing 2 visitors. I'm going to need help with transfers. Do you have a Hoyer lift? Whatever it is you need to help to transfer, let them know. You may also say, I don't want to transfer. What can we do so I don't have to transfer? Do they have a motorized room? Do they have a motorized bed that goes very low so that you don't have to walk up those little stairs and get onto the thing? Do they have a bed that can go very, very low? In my office, we have one that goes down to, it's like basically, 8 to 10 inches off the ground. So, sometimes if we're seeing people who are little people, it's no problem at all for them to get on the beds. And then, are you getting 2 services? Do you need an ultrasound and a pelvic exam? Do you need a pelvic exam and whatever else? Can it be combined into a single site? Can the doctors come to you instead of you having to get dressed and switch between sites? So some common issues that we talk about that are definitely challenges for a lot of people, but no different for anyone else, but can be more frequent in people who have neuromuscular issues: UTIs, challenges with the pelvic exam, mammograms, contraception, and sexuality. I'm going to talk a little bit about all of these, I hope. Keep in mind that a pap smear is not the same as a pelvic exam. Pelvic exam is something you're supposed to get every year. Someone's supposed to look at your girl bits just like they look at the rest of you every year, and make sure that everything is healthy and still in its original form, or at least in its age-appropriate form, and to make sure that there are no concerns, right? You can still get things like melanomas, you can still get warts, you can still get skin cancers, you can get all sorts of things that happen on the parts that are, as my husband's an internal medicine doctor, the bikini medicine, right? The things that are covered by the bikini still need to get looked at. And GYN care is more than just pap smears. Okay, so do you need a pap? If you are under 21, we no longer recommend you get pap smears at all. If you're 21 to 29, at most every 3 years, and you can do HPV alone, which is a blind swab between 25 and 29, which is an easy way to see if you're at risk. Between 30 and 65, you get HPV and a pap every 5 years. PAP alone is what that should say, every 3 years, or HPV only every 5 years. And then after 65, if you've never had abnormals, you never need another pap smear, although you still need pelvic exams. And no abnormals over the last 2 to 3 that have been done. So over the last 15 years, you're done as well. And so that can be very helpful. So exceptions are people who are HIV positive, immunosuppressed for other reasons, have cervical cancer, or who were exposed to DES before birth. You had to have been born before 1971 to have that happen. So there's not too many reproductive age people, although there are people who are older, obviously. HPV testing, you've either been exposed to HPV, you just have, whether you've had sex or not, almost everybody has been exposed to HPV. And if you haven't been exposed, you will be exposed. HPV is incredibly common in the population. So if you are even considering getting vaccinated, please do. It does definitely decrease the risk of cervical cancer. It does not only decrease the risk of cervical cancer, it decreases the risk of head and neck cancer, because HPV is one of the leading causes of that as well. It can be done with a blind swab or from a pap, and it can be self-collected, and it should be done even if you're vaccinated, because the vaccine only covers, I believe, 4 or 6 versions, depending on, or 4 or 6 subtypes, depending on which one you get. Blind paps, so this is no speculum, just wipe in the vagina with the pap smear brush, and you know, are satisfactory in about 50% of the time. And so if you don't get a transition zone, but you still get an okay pap, you have to do it every year, but still it's a blind pap. You don't have to do the speculum exam. And if you don't love a speculum exam or you can't get into position, that can be helpful. So let's talk about some of the mobility things for the examination table. So plan for your visit, consider what is most comfortable for other ways that you do peri-care. So what is the most comfortable way for you to lay for sex, or to lay for changing pads, or what is comfortable for you. Teamwork is great for teens and adults. I really recommend avoiding having a family member as aid unless it's discussed with a patient first or the patient requests it. And parents, please don't be offended if your teen asks that someone else be their support person or their person for positioning. It really does help them to self-advocate and to disclose to their physician. Use the right equipment, make sure your bladder's empty ahead of time. Leg supports are completely optional. And if your doctor asks, you want a Peterson, not a Graves. So these are, when we think of traditional GYN bed, we think of this thing on the far left here, but there are beds that motorize all the way to the ground with no arms for easy slide over. There are these lovely ski boot versions if you really do need to get in stirrups for some more examination than just a routine pap smear, that can really help hold the legs in position where you don't have to just balance on those little stirrups. They actually do all the work for you. They're completely hydraulic. There's also ones that look like this that go under the knee, that, work simply by, again, the leg is laid over that and the whole bed moves. So there's minimal work that needs to be done by the patient. Additionally, you don't need to use stirrups at all. Side lying is actually how pap smears and pelvic exams were initially described, and I actually think are one of the most comfortable ways to do pap smears and pelvic exams. Frog leg, straight leg positioning are all fine as well, but side lying with the knees elevated is actually the most comfortable for many, many people, who, especially people who have hip tension or tightness. Okay, so we talked about this a little bit. Am I going backwards? Not meaning to. Okay, mammograms. Only 60% of people with disabilities have mammograms compared to 75% of people without. And people did ask me to address this very specifically. So call ahead, just like with a GYN exam, contact the staff and let them know. Ask if the machine can be adjusted, or if they have a special site that has a machine that goes very low for wheelchair users if you need to be a wheelchair user. If you aren't a wheelchair user, but you say, you know what, I really need to be in a chair, I can't stand for that long, and get in position, and all the machinations they make you go through, ask if the machine can be adjusted for chair sitting. Provide specific details about your physical issues. I have spasticity, I can't raise my shoulders, I can only raise my shoulders to the halfway. Whatever your issue is, make it so that you specifically say, these are the challenges I'm going to have, how are we going to work together to do it? Wear a top that opens in the front if you don't want to switch to a gown, and either no bra or a bra that's very easy to remove. Don't wear any deodorant or body powder the day of your appointment, because they will interfere with your x-ray. And consider bringing a friend or a family member to assist with the dressing and undressing, and even helping hold you in place if you're struggling to you just want some support during that. Remove the arms of your wheelchair if possible to allow the chair to fit under the shelf that your breast goes on. Bring your foot rests in as much as possible so you can get as close to the machine, and the technician should help you understand where you need to position relative to the machine. Technologists should be able to use positioning aids like foam blocks or pillows to help you get in the correct position and remain stable during the exam. Like, it shouldn't be a lot of work for you. They should position you in a way that the machine is like holding you essentially in position. And they need you as upright as possible. So the more that you can help them understand how to best do that, that's ideal. And after you find something that works, right? Like, 'cause it might take a couple of tries. If it's your first one, say, let's write down what worked so that it's in my chart next year so that we know I need machine 6 with 2 pads and, an extra person to help with arm holding during this exam. And I put 2 links in here that are tips for mammography staff that you can actually either bring or you can send in your MyChart or your portal to the place where you're getting your testing and say, hey, I'm coming in. I have some very specific mobility challenges. I don't know how well trained your staff is. I found these great resources online. I want to make this great for everyone. Here's some things that you may find helpful. Okay, so let's talk about menopause a little bit. One of the things that we talk about a lot is whether to replace or not replace hormones. So, benefits of replacing are hot flash management, cardiac disease, bone health, and skin health. Clotting risk, breast cancer can go up with these. Cardiovascular improvement only helps if you take them early in your menopause journey, and they may cause ongoing cycles and bleeding, which if that is a big challenge for you, replacement may continue that. If you have underlying liver disease or hypertension, it's probably not your best choice. It should be an individualized decision is how our society leaves it, but there is definitely a benefit to bone health. And we know that many people who have decreased weight bearing have higher risk of bone health issues. It does protect against cardiovascular disease in those who have reduced exercise. And if you're struggling with hot flashes or skin breakdown or UTI, hormone replacement helps with all of those. But there is a clotting risk, and immobile people also struggle with clotting. So if you're going to do HRT, it's best within the first years after menopause and before the age of 60. If you still have your uterus, you need a progestin with your estrogen. If you have a history of breast cancer, hypertension, active liver disease, or blood clots, and then immobilization is a relative contraindication, so it needs to be a risk-benefit discussion. If your symptoms are all vaginal, consider just local replacement instead of full body replacement with pills. And delivery methods include creams, vaginal suppositories, or rings if you're struggling with the hepatic impact. People ask me to address testosterone as well. Testosterone can be a useful adjunct to care. However, don't jump right to testosterone. Start with estrogen first. So you really need to be fully re-estrogenized to make sure that it's not just an estrogen deficient issue before adding testosterone. You should do a short-term trial, no more than 6 weeks. If it's not helping your symptoms, if it's causing androgenic side effects, so I'm by my heritage going to have a full goat beard by the time I'm 60, and so if I am experiencing more dark hairs or enlargement of the clitoris, things like that, those would be things that you would say, oh no more testosterone for you. We don't really have normal ranges for these hormones, and so you can do a free androgen index, and it should be aimed to be less than 5% of your free androgen should be from testosterone and after treatment. If it isn't working or you're noticing side effects and you haven't noticed an improvement by 6 months, it's unlikely to be beneficial. And this is why our societies do not recommend the pellets, because what if you all of a sudden discover that it's causing you to have changes in your hairline, like you're losing the front of your hair like men will, or you're starting to get facial hair or other things that you find unacceptable. There's no way to get that pellet back out. So it's really not recommended. Okay, somebody also asked me to talk about saffron. There's nothing specific to neuromuscular disease. There is 1 or 2 randomized controlled trials that did show improvements on psychological symptoms with menopause when people were given it twice daily. Now, keep in mind, not all extracts and supplements you buy in the store are well regulated. So this one was a very specific one created by a drug company where you know exactly what's in it, may improve depressive and anxiety symptoms, but no difference in vasomotor or somatic symptoms, and the long-term data is unknown. These trials were relatively short, but did show some improvement. People ask me to talk about ALS specifically in hormones, and for a long time, only men with ALS were studied because more men get ALS, not thinking about the fact that why do more men get ALS? And so it's important to think about what that might be. It turns out that subcutaneous fat and having a higher estrogen state, both of those things are true statements of people who have more surface fat actually raise their estrogen levels, has been shown to improve slow progression, correlates with survival time and time to diagnosis. And the pill actually, again, extra of these hormones decrease the chances of getting ALS. So it may be that if ALS is a disease you're struggling with, hormone replacement may actually be more beneficial to you than to other people. And so you may look at that risk benefit conversation with your doctor and say, you know what, I do think we want to talk about HRT because of these other pieces. Testosterone is much more complicated, but the free testosterone does appear to affect development. All right, let's talk about bladder symptoms a little bit. So urinary incontinence comes in two versions. It comes in the stress incontinence. This is the why your mother can't laugh at your jokes anymore after, I should not say my mother, why I can't laugh at anyone's jokes anymore, because when you cough, sneeze, laugh, exercise, you get changes in your Valsalva, and it causes urinary incontinence. So that is the stress incontinence. The pressure goes up in your belly and fluid leaks out. The urge incontinence is the best example is probably when you get home and you know you're going to go inside and use the bathroom and you're like struggling with the key and your bladder is like spasming, like I got to go right now, right? And you got to like run to the bathroom. That's the urge incontinence. So they have different reasons and they have different treatments. So stress incontinence has to do with weakness at the bladder neck. Often this is associated with childbearing, but it can just be associated with age. And it basically is the pelvic floor, the muscles of the pelvis that are getting older and weaker. And so you get leakage of urine. So you can imagine that people who have issues with neuromuscular issues may have increased weakness in the muscle floor as well. There's not specific data on this, but it is kind of an association that is talked about. And behavioral changes and pelvic floor physical therapy are two of the first things that should be done. Pessaries, which is looks like a little rubber donut that goes inside the vagina and helps hold everything up, can help as well. And then surgery to address weakness in the bladder neck can also be helpful. Urge incontinence, on the other hand, is the bladder starting to squeeze to say it's time to pee, and you being like, but I'm not at the bathroom yet. And so physical impairments that slow down your ability to get to the bathroom when you need to urinate can make for functional incontinence, but it can also just be bladder spasm as well. So behavioral changes and physical therapy can help with this. There are medications that can help with this, and nerve stimulations as well as Botox injections can actually help with this as well. There are over-the-counter supports. So I talked about kind of those donut rings that you would get from your doctor. Those are these blue ones down here. But there are this one that looks a little bit like a tampon. The Poise version is what it is. There's a couple different, it looks like a white plastic, looks like a children's top, for lack of a better reason, that you can buy on the internet. And they're all just meant to go in the vagina and help hold things up and provide support and prevent leakage. And this came out of data that's like people would say, oh, well, I wear a tampon to exercise because then I don't leak. And so now somebody's marketing it specifically for that. There is a whole website to find people for pelvic floor disorders. And so if you are struggling with any of these, I encourage you to find a urogynecologist, not a urologist, but a urogynecologist who can really help to guide you through this process. And often they either have a great relationship, excuse me, with a physical floor pelvic therapist, or they have one in their office. Kegels, which is the home version of PT, is essentially a weighted, like the kettlebell for your vagina to help exercise your vagina. And there are great handouts and information on the APTA website on pelvic health that has a lot of really great stuff, as well as this pelvic rehab website. Okay, so I'm going to skip through some of this, but we're going to talk briefly about parenting and pregnancy. There is no wrong way to parent. And really, what is going to drive what you need is going to have to be with what your specific manifestations of your specific disease is. In general, you need a maternal fetal medicine doctor because they are going to be the people who are most knowledgeable about rare diseases. Most of what we take care of are people who are, each themselves kind of a one-off. You're going to want to make sure that you get genetic counseling to talk about whether there are implications in the future for your care. And you are going to want to make sure that you talk about whether having a child with the disorder is okay for you or whether it's something that you want to avoid. So people have asked me to talk about how IVF works. IVF works by stimulating the ovary. You then take the eggs out. It's called harvesting. It's a terrible term, but long story long, they actually use a small needle through the back of the vagina, take the eggs out, put them in a dish with some sperms. You can either choose the sperm and put them in 1-to-1, or you can kind of just let them do their thing in the dish and you make little embryos. So egg and sperm meet together, you make embryos, they grade the embryos, and then they put them back inside the uterus on a certain number of days after they've been growing in the dish and allow them to implant in the uterus. So the basic principle is that you stimulate the ovary, you harvest these little eggs, then you take semen. It can either be naturally ejaculated, where you can just mix it together with the eggs, or if you have somebody who can't ejaculate, you have to individually pluck the testicle. You have to individually biopsy the testicle and pluck out sperm. And then those you can actually like stick directly into the egg. So it kind of depends on how you harvest it. Then you score the embryo and implant the very best ones. The reason I'm going to try to stay away from a very specific discussion of each neuromuscular disease is because each one could be an hour, as far as I'm concerned, on what to manifest in pregnancy and what to do in pregnancy, because this is just a very loose drawing of each one has a very different pattern of effect. And so how we manage in pregnancy is going to be specific to not only the disorder in question, but also to the person's individual manifestations. But in general, if we look at things like early pregnancy loss, we see that it goes up a little bit in people with SMA and DM2 and potentially DM1, but that our other disorders are very similar to the baseline population. And when we look at obstetric outcomes, keep in mind that this is the baseline population risk of these things. So people look at this and go, oh my God, there's a 15% miscarriage rate. Just walking in the door, in general, people have about a 15% miscarriage rate. So some of these that are saying like 6 and 5%, probably not real, right? So basically everybody is pretty similar to the reference population. When we look at hypertensive diseases, again, about 6% of the population gets those. So very similar in people with neuromuscular diseases. Polyhydramnios, myotonic dystrophy is an outlier here because of the risk of congenital versions of that. Placenta previa is also an outlier here because myotonic dystrophy is one of the only ones that has effects on the uterine muscle, and so the placenta doesn't move how it should. It doesn't form in the correct place because it doesn't because the musculature of the uterus is different. So that also affects this, the urinary tract infection risk, the preterm delivery risk, the cesarean delivery risk. And so, but you can see that in general, most people do quite well. The SMA group has a little higher rate of preterm delivery. Everybody has a slightly higher rate of cesarean section, although, I shouldn't say that. Almost everybody has a similar to slightly higher rate. FSHD potentially lower, but I think that again is a very small sample size problem. And instrumented delivery, meaning needing help with forceps or vacuum, slightly higher than the general population, again, just fatigue being an issue. So I'm going to briefly talk about healthy pregnancy care because we're going to run out of time, but keep in mind that you need a full team to be helping you with your pregnancy. That is going to include a cardiologist if you have cardiac manifestations, a pulmonologist if you have pulmonary manifestations. You need a team lead, which in general will be your maternal fetal medicine doctor, and you'll need a multidisciplinary team to plan for your delivery. Because these deliveries can be more complicated, you're going to want to make sure that your team is aware of what you need, especially in people who have limited mobility in their hips or their pelvis or use wheelchairs full time. People who don't use wheelchairs full time may find themselves using wheelchairs full time as the pregnancy progresses, as their weight changes. ICU admissions go up, especially for those who have any aspect of restrictive lung disease. And regional anesthesia is generally preferred for most patients, even if they have neuromuscular disorders. However, if you have severe scoliosis or vertebral issues, this may be more difficult. And with general anesthesia, there is increased risk because of the atrophy of the neck and the mouth, and we do need to make sure that your anesthesia team is aware of those risks. Keep in mind that some of the neuromuscular disorders have hypersensitivity to neuromuscular disorder agents, and so we want to make sure that again, we have a team before we get to the big day so that everybody is aware of what we need to be careful with. And just keep in mind that there are other things that can be done for pain, things like tap blocks, which is numbing the abdominal wall, ice packs, but need to be careful with reduced sensation. Advocate for yourself to stay a couple extra days. Caring for a new baby is a new ADL, and you definitely need help. And make sure that if your partner also has mobility needs, that the team is aware of that before, so that your room and your setup can be appropriate for both of you. I like this website for basically baby hacks for people with different mobility challenges. This one is SCI Parenting. It's out of Europe. It was started as one specifically for spinal cord injury parenting, but it has a lot of really great, basically MacGyver hacks for different ways to use different things to do childcare if you're struggling. And I don't really have time to do my whole section on healthy sexuality, but just keep in mind that healthy sexuality is a routine part of of adult life. And there are lots of great sex therapists out there and referrals. And so I encourage you to make that part of the conversation that you have with your doctor and team. All right, I'm going to stop sharing so that I can answer some of these questions in the chat, and that so people can ask me questions, because I know that I could talk about this kind of thing forever. So whatever I can answer for people, please ask me anything, as they say.
Thank you so much, Dr. Thornburg. We do have a list of questions that our team has collected from the chat. So we can just start, I can field those to you and we can just start going through them.
Great.
So the first question that came in, and this is a bit specific, but related to some of the things you were talking about earlier. Someone said, my mother-in-law and sister-in-law have Thompson's non-dystrophic myotonia congenita and have endometriosis and more symptoms during their period. My mother-in-law also had challenging pregnancies with health complications, including premature deliveries. And this lady, she's asking, could this be related to their condition? She has a daughter and she's just trying to learn for her daughter's sake what might be issues for her later on.
So it's hard to piece which piece is from the Thompsons and which one is from the endometriosis. Endometriosis can be a real bad actor in pregnancy, because it can result in, it results in painful periods because it results in a lot of scarring inside the pelvis. So it may be that your mother-in-law's issues with her pregnancy had to do with her endometriosis and not with her Thompson's, but it's hard to know, right? We also know that it is in the myotonia family. And so if you're struggling with the relaxation piece or the muscular tension piece during pregnancy or childbirth, that may be part of it too. So um, the stiffness, certainly the stiffness in the hips, I'm sure all those things were challenging in the pregnancy, but I don't know of an association with endometriosis and Thompson's. I mean, I don't think, that's just too niche for anyone to have done that study because it's like two rare diseases, like how many you would need a very large group to study that. But it may be that those two things are, it may be the endometriosis more than it was the Thompson's, but the combination probably was very challenging. If this person has a previously healthy child, if their delivery went well, one would assume that it was more the endometriosis than the Thompson's itself.
Okay, great. Thank you so much. I like that about endometriosis being a bad actor. That's a
It's kind of a
that's a
bad
good way to
actor.
put
Yeah,
it.
absolutely.
All right. So our next question was, I have G&E myopathy, and a maternal fetal medicine specialist advised against pregnancy for me. Could you please explain what risks you see in a patient with a neurological condition like this?
So, um, I'm surprised that they recommended against pregnancy, right? So it's a progressive disease, but it can have a pretty wide progression. It kind of depends on, like a lot of things, what the individual manifestations for that person are, right? So,
Mhm.
um, if you're a person who's relatively mobile and in relatively good health and, has some mobility issues, but is doing well, I don't see why you couldn't have a pregnancy with it. The two things that generally make MFM physicians say, who think really carefully about this are people who have restrictive lung disease. So people who are have changes, especially changes in their spine or their chest, that's making it difficult for them to get enough oxygen in, or people who have cardiac manifestations. Now, not all of the neuromuscular disorders do, but many of them do. And so if you have those two things, those may be more the driver than the disease itself, especially the respiratory one, because there is a lot of challenges with getting oxygen into a fetus. And that is one of the things that we just don't have a lot of tools to overcome, right? Like there are a lot of other things we can do, but you only have the lung capacity you have. And so it may be that your doctor is more worried about those pieces. You know, if it's super important to parent for you, one thing to think about is whether you're healthy enough for IVF and surrogacy. If it's important to have a genetic child. Adoption is an option. You could get a second opinion on, why they feel that way. Um, or if there are things that you could optimize, that it's like, well, we don't think you're healthy enough for pregnancy now, but if for example, I see patients a lot who I say, I don't know that you should have a pregnancy now with your diabetes very much out of control. But if you get your diabetes under control, I think that it could be a reasonable journey. And that doesn't mean I'm saying no, but it can feel like a no. So I think
Mhm.
it kind of depends on what the primary issue was.
Great, thank you. That was very thorough. So our next question was how. So you mentioned earlier when getting a hysterectomy when you're done having children. How do you justify or get insurance coverage for a hysterectomy when you feel like you're done or you're ready for that step?
So typically you have to show that you've tried other things and they have been ineffective in controlling your symptoms. So have you tried an IUD? Have you tried hormone therapy? Have you tried an ablation or something else where it's like my symptoms are no longer manageable? Um, yeah, unfortunately, the sticky wicket of all of American healthcare is insurance. And so it may have to be a prior auth and a conversation, a peer to peer by the doctor and somebody at your insurance company about why a hysterectomy is a better choice than something else. Basically, they don't want people to have major surgery with the cost and the risk that that entails until they've tried something that is um, less invasive. And so it may be that you have to, like a lot of things, you have to show that you've tried something else before you can have the first thing. So think about it like people who want to qualify for Ozempic. I saw somebody was in here on talking about PCOS, right? The GLP-1s have been shown to be great for people with carb intolerance. And um, you may have to show that you've tried something first before your insurance company will pay for the more expensive thing, unfortunately.
Yes. We're all familiar with that insurance piece.
I mean, I'd like to tell you it's like not a problem, but I mean, like it's a problem even if you're a doctor, right? Like I still fight about it for my kids too. So,
Oh, yes. So we also had a couple questions about ovarian cysts, one in a more general sense, one for mitochondrial myopathy in particular. Do you know if there's any link between neuromuscular disease and ovarian cysts?
I don't. Um, you know, Again, ovarian cysts, we all should be making at least one every month. So that's just a normal process of ovulating. So it's really a matter of if they're large, if they're sticking around, if they're causing symptoms. And so it may be that hormonal suppression for somebody who's a recurrent cyst maker may actually be really helpful on a lot of fronts. And so that would be my number one choice is to not let them blame it on the neuromuscular disorder and to say, well, what else could this be? And what therapies would we do if I didn't have whatever the thing is here? And say, let's pretend, right? Like, what therapies would you offer? And I think that can be really helpful to reframe the conversation for people.
Yeah, absolutely. I love that input. Thank you. So our next question was, this lady is 20 years post-menopause, but she's still having hot flashes. You've probably seen this in your practice at points. Are there any good ways to control those hot flash symptoms long term?
So it's a great question. If you're no longer eligible for HRT, and it may be that, you're one of the people who's having a slow menopause transition and you need HRT for longer, right? I mean, not everybody menopauses at the same rate, right? Like, I have aunts who are like, did I even menopause? And I have other aunts who, were like carrying around their own personal fans for it felt like my whole life, right? So, I mean, everybody's different. So you may need more therapy for longer. There are other medications, though, that are not hormones that have been shown to help with hot flashes. So gabapentin has been used in some studies. Even some anti-epileptics have been used. So it may be that your doctor needs to think about other choices if you're really struggling with those vasomotor symptoms, because they are very unpleasant. And don't let somebody be like, oh, it's just the change. Um, I welcome any man to experience it and then tell me how it was no big deal. So,
Right. I love having all the ladies in here
yeah.
today. So on a similar or related topic, someone asked if there are any studies to show the effects of hormone replacement therapy, estrogen in particular, and helping to keep muscle. So, is there anything related to HRT and muscle?
So, HRT does help some of the bone and muscle loss that we see that happens as we age. But the biggest things that help with that are continuing to be active in whatever form that looks like, right? So it can be as simple as like, you know what, the heaviest thing I can lift is a soup can, but I'm gonna do it, right? Like it's whatever you can do to keep muscular tone as we age, and everybody should be trying to do that. Additionally, weight bearing, and again, whatever that looks like for you, because that does help with bone density as well. And menopause does make those muscular symptoms, the loss of muscle, the muscle pains, all of that is worse. Think back, I mean, I know I'm like challenging myself here, but think back when you were like 11 years old or 9 years old, or, people are going through puberty even earlier now. Actually, 9 to 11 is considered very normal for American children now. But that their remember, like, everything hurt, you thought you were dying, like you were uncomfortable in your own skin, you got to do it in reverse. And so it may be that hormone replacement can help with that if you're really struggling.
Okay, great. That's good to know. So we do. I know we are a little over time. We have like 3 or 4 more questions, if you don't mind sticking
Oh,
with
that's
us.
fine.
Wonderful. Okay, thanks so much. So our next question's a little more specific. Definitely some conversation to be had here. I am 68 and have weakened abdominal and pelvic muscles, fatty atrophy from RY1 related congenital, recently experiencing an increase in loss of bladder control, mostly when standing after being supine. There's no evidence of UTI, but has not had urodynamic testing. Is there any data to suggest that myopathic muscle weakness can be cause of challenges with urinary incontinence?
There isn't specific data, but it's one of those things that, like, as my grandfather would say, it just makes good sense, right? Like, it probably does, right? We don't have, I can't prove to you based on a study of 100,000 people that it does, but anecdotally, it does. People who have muscular weakness or muscular spasm, there is no question that it makes a difference in what happens in their bladder. And so I strongly recommend that this person get in to see a urogynecologist to talk about pelvic floor PT, to talk about optimizing the muscle that they still have, and making it work for them and learning how to use it. That they talk about, they're talking about changes in position. That's a very typical time to lose bladder control because you use a ton of your belly wall and you make that big, to get up, and that creates a lot of pressure in your abdomen, and your bladder's the point of least resistance, right? It's the same way that sometimes you get heartburn when you do that too, right? It's like everything's got to go top and bottom. So, timed voids can help, not letting your bladder get over full. And then, this is a case where a pessary or bulking agents may be really helpful if there's weakness in that bladder neck. And so getting in for those urodynamic assessments can be really, really helpful.
Great, thank you. So our next question, going back to HRT, I have heard that menopause can make muscle symptoms worse due to estrogen receptors. Would HRT help with muscle pain that worsens during menopause?
It typically does, but again, if you try it and it's not doing what it needs to for you, then you can switch to one of the other therapies.
Great, thank you. Just a few more questions here. Oh, and we did have a follow-up question regarding the can mitochondrial myopathy cause ovarian cyst question. Could it also cause early periods, or is there a connection between neuromuscular disease and early periods?
I have not seen that. We don't typically see variations in hormone levels, um, typically. And like I said, people are starting to get periods younger and younger. Everybody's got a theory about it. It may be that because children carry more weight, and fat is estrogenically active, so that's pushing people to an earlier menarche, the start of periods. It may be that changes in our food supply and the hormones we're exposed to is making that happen. But it is not uncommon to start to see pubertal changes in kids early puberty changes in kids as young as 7, and periods somewhere between 9 and and then the upper range being much higher. But it is all over the map. People who are thin tend to menstruate later. People who carry a little more weight tend to menstruate earlier. African American descent people tend to menstruate a little earlier. So it may, and it also has to do with your family history as well, right? If your aunts all that got their periods at 9, 10, 11, that's probably going to be your journey too.
So just a lot of factors there.
So many factors. And if you're ever concerned about your child and saying, I don't think you should have pubic hair yet, or I don't think you should be so stinky yet, like this is not normal, please take them to your pediatrician. There are things that they can do. And one of them is they can actually do their bone age, right? And really make sure that they're not going early because we want them to get to their full height and all of those things.
Okay, great. Thank you. Um, Our next question was, would you advise against pregnancy if someone is on a ventilator?
Pregnancy on a ventilator is tough, right? It's a lot of things that need to be balanced and managed. It kind of depends on how much ventilator. I mean, that sounds stupid, I realize, but let me explain a little bit, right? Like, so somebody who's using a ventilator occasionally at night or when they get sick, right? Who's intermittently doing it. Somebody who's trached, but, kind of using it as support once in a while, probably can do okay. Like, but somebody who's completely vent dependent, who has no extra lung capacity, is going to really struggle. So, again, we don't have anything specific for neuromuscular plus ventilator, but we do have ventilator in pregnancy, and we do have um, cystic fibrosis with chronic lung disease, and we do have more common disorders they have bigger studies, so people who have restrictive lung disease for other reasons, and we know that they are going to have a very high rate of needing to deliver early because they can't support two people as you get to larger sizes. People who are really struggling with ventilatory support because of their body habitus, so people who have a lot of changes in their spine, if you then add an infant to that, you can imagine that as someone's butt starts to get up in your chest and you're trying to recruit the lung that you have remaining, it can be very challenging. So it kind of depends on the total picture, how much you need it, why you need it, is it all the time, how well controlled on it are you, how on the edge are it with just supporting yourself with that, and how do you do many people who are on a ventilator really struggle with weight gain, and it may be a struggle for you to grow a healthy sized child with chronic lung disease. That can be one of the biggest challenges.
Yeah, absolutely. Thank you.
No problem.
So our next question was, I'm not able to take hormone replacements because of a history of a tumor in my breast. What would you advise as a replacement or an alternative in this instance?
That is a really tough one. So it kind of depends on the symptoms. If it's hot flash symptoms and the vasomotor symptoms, people are trying things like gabapentin. If it's vaginal symptoms, talk to your cancer doctors and your gynecologist, but sometimes topical estrogen is okay. So you could do vaginal creams and still get the relief from the dryness or the painful sex, but not get the risk of recurrent breast cancer. So it may be that, yes, you're not a candidate for the full enchilada, but you might still be able to get the taco sauce. So think about if you can get part of what you need to get your symptoms relieved, depending on what they are.
Great, thank you. I just love your metaphors. I think it's so easy to understand. So our next question was, we've had a few more questions come into to the chat since we've been talking for a while. What things can I do when I have a very heavy flow, large clots, severe pain, and I am chair bound with ALS, going through period underwear within the hour?
That is the
How do I
worst.
prevent yeast infections and other issues when it's hard to get changed or you're having frequent accidents?
That is exactly the story where I would talk about what are your goals for future fertility? And if you don't have goals related to future fertility, if you can take Motrin, if that's allowable, like if you've not had any GI things, starting a round the clock course of Motrin going into your period will often help your period be lighter. So you could try that. Are you a candidate for hormone manipulation of your periods? So I don't remember if they said, but like, could you go on the pill? Are you a candidate for an IUD? Even if it doesn't stop your periods, maybe it makes them more tolerable. Yeast infections and skin breakdown with that amount of bleeding is a serious issue. And so, free bleeding, having some time during the day where you're using basically like Chuck's pads instead of trying to wear underwear and pads and things like that, and you're bleeding through them. And that amount of bleeding, like every hour, filling pads, filling diapers, things like that, can also just be a health risk. That's a lot of protein and blood loss. And so, it don't think of it as like, well, this is, I guess I hear this a lot from like my male colleagues. Well, it's just, it's just their period. I'm like, okay, if it was your period, you would not be so cavalier about this, right? Because it can be a serious health concern. So it may be that you risk in for, additional care without having to try a lot of like the basic stuff, right? That is, is losing that much iron and that much blood, is it affecting your health in other ways, in a way that, you really should be front of the line for getting really evaluated and care. And just because you have ALS, I think you said this person had, doesn't mean you don't have something else. You could have fibroids, you could have a polyp, you could have something that's easily treatable. It's just getting put in the bucket of, well, it must be from your ALS, versus looking for, the regular stuff that us gynecologists find. So, you know, I think that would be worth looking at too.
Absolutely, yeah. And having that advocacy piece of it, can we check this? Can we check something else? Absolutely.
Yes, what else can we do? And, I don't know if you're getting infusions or anything else, but if you're bleeding that much, asking whether iron therapy, IV iron therapy between your periods may be something that your doctors are like, oh yeah, I never thought of that. Like if you're really struggling with anemia related to that much bleeding, even too, to help support that. But I
Yeah,
would absolutely do a barrier cream leading into your periods. And then um, if if you don't hate it, yogurt will help with yeast infections too. Making sure that you're keeping um, your gut bacteria balanced too.
great. Yeah, great advice for all of us. Thank you. So just a few more questions. I have been diagnosed with ALS in my 20s, mid late 20s, but I have had known issues with endometriosis, PCOS, and PMDD since my adolescence. Are there any correlations with this that you know of, or general women's health correlations with ALS?
Well, generally, people with ALS have do better with estrogen, right? Like estrogen helps to slow the progression and helps to minimize symptoms. So it's interesting that you're having kind of all the worst of both, right? And so it may be that rebalancing out your periods from your endometriosis and your PMDD standpoint. So, like oral contraceptives, which are very effective for both of those, may be something that you really need to talk to your doctors about, because they definitely um, assort together people having endometriosis and pelvic pain with periods, and all of that kind of fitting together. And I wouldn't want to see you completely eliminate your hormones, like doing things like I talked briefly about something called Lupron, which completely shuts down that whole axis, because we know that can increase progression of ALS. So when people are less estrogenized. So thinking about doing it in other ways, like whether that's oral pills, or whether that's IUDs or things like that, I think that would be probably where I would start, because I wouldn't want to shut down that access and then potentially like trade one problem for another. But
Okay, thank
this is
you.
a total guess, right? Because
Hmm.
every little piece is going to be different. So I think you're going to have to find somebody who's willing to like try something and see how it works for you.
Yeah, absolutely. And a follow-up question to that, so this person with ALS is interested or curious about pregnancy with ALS. What are the concerns with ALS in pregnancy, besides the respiratory problem piece?
It's really the respiratory piece.
Okay.
Um, Most people, even so, like imagine that you had no mobility below the neck, right? Like you had a complete spinal cord injury. most of those people that I take care of will still deliver vaginally. The uterus can do it all on its own. So most people, it has to do with keeping the rest of their human healthy to support the pregnancy. So it has to do with whether your heart and your lungs and your body can handle the stressors of it. And the mobility piece, as you gain weight, are we going to struggle with bed sores? Are we going to struggle with clots? Are we going to struggle with, going from mobile to immobile? That's often really hard for people when they're like, I do fine with just assistive devices, and now I'm fully wheelchair dependent because I gained 50 pounds because that's what people do in pregnancy, and my center of gravity is bananas and I can't keep myself from falling over. If your life's not set up for that, that can be a big challenge. So,
Yeah,
yeah.
absolutely. So this is our last question that we got in the chat. If anyone had a question that they put in at registration that they really want answered, please go ahead and put it into the chat again, because we don't have time to get to all the rest of our registration questions, a lot of which Dr. Thornburg did address in her presentation as well. But our last question was someone asking, where can I go to get more info on pregnancy for LGMD patients or just in neuromuscular disease patients in general? Do you know where someone could go to get more information after the webinar?
That is a great question. And I wish that we had really, really, like, I could tell you this is the monograph to go to and read. The FSHD Society is about to publish like a full, like, life care thing on FSHD. And I happened to get asked about something about it. And I was like, hey guys, can we put a pregnancy section in? And they were like, oh, right, which is what happens when you're in a room with a bunch of male neurologists. And so that one's going to have a pregnancy section, and we're actually going to write an entire separate chapter just for FSHD on pregnancy because I think it's a problem. I agree, we need one on each one of these diseases. But I would start with some of the more common kind of neuromuscular grouped papers and kind of get what you can from those. Um, uh, LGMD tends to do pretty well in pregnancy as long as there's not a lot of respiratory stuff. Again, I keep coming back to that, but that's always that sticky piece. And one of the biggest issues, of course, being falls, right? So if we want people to be safe and your center of gravity is really shifting around, and people tend to fall in pregnancy even without neuromuscular challenges. So those are going to be kind of those two big things that your doctors are going to want to do. And I recommend asking for a consult with a high risk MFM, because what we will do is have to go to the literature and dig out all those studies and find all that stuff. Genetic counselors often will help with that too. So these can be places where not just a regular genetic counselor, but a reproductive genetic counselor, right? Somebody who's specific to pregnancy and talking about pregnancy concerns may be able to help you find the best resources as well. So those would be the two places I would start. And again, I caution anyone going to the literature, but please, please, please be careful in the literature because it is like a group of patients. Often it's a whole bunch of versions of one disease stuffed together, right? It's like the common and the super rare, and rare things or things that don't happen very much in obstetrics are going to be over or underrepresented depending on if they happened. And your disease may be far less severe than the people who were in the study, or the opposite, right? And I want you to get what's specific to you, not just believe these very limited data that we have. I see somebody asked about coming to see me. I am in a MFM practice in Rochester, New York, and we take referrals from anywhere and we do telemedicine. So if your insurance covers care in New York, I'm happy to see you, and I do most of my consults by telemedicine. be happy to talk to you. And infant mortality increases depending on ethnicity. This is a true sentence, right? We know that infant mortality and neonatal morbidity and mortality and maternal morbidity and mortality are not evenly distributed ethnically or racially. And neuromuscular conditions in general, let me say this carefully, do not unless they have severe infant versions, right? And some of these do, and some of these do not. So I don't want to say no, but many of these are not the kind of thing we expect to be instantly active in childhood, with the exceptions of like your congenital myotonias, your congenital neuromusculars, your SMA1s, so I don't want to say not for sure, but in general, most people are not an infantile issue.
Yeah, absolutely. And if I can speak from my personal experience as a person who's given birth and I have an autoimmune disorder, having a perinatal specialist, even just going to a visit or two and asking them those specific questions about your diagnosis, can be so important and effective for your pregnancy. So I think that's all that we had for you today, Dr. Thornburg, but I want to thank you so much for this wonderful presentation. This is something unique that we've done at MDA, and there's definitely a need there, and we hope to explore this topic more in the future. But we greatly appreciate you being here, staying long to answer all those questions, and for all your support of our community. Thank you.
No problem. Also, the MFM website has a list of MFMs across the country, and it'd be good to make a relationship with one in your area. So
the MFM website. Wonderful. Thank you so much.
All right. See you soon. Bye.
Thank you, Dr. Thornburg. So once again, MDA would like to thank our program sponsor, Regeneron Pharmaceuticals, for partnering with us on today's webinar. This year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular disease, their families, researchers, clinicians, and volunteers who boldly drive our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum forward to transform progress for people living with neuromuscular disease. To learn more, visit mda75.org. Last but not least, we again invite you to join the MDA community. Joining is free and will help you stay up to date on our programs as well as on the latest research. Please scan the QR code with your smartphone or visit the link in the chat. I will leave that up for a moment, as I also mentioned that if you did not get your question answered today, or if you have any follow-up information that you're curious about, please reach out to our resource center. Our resource center is going to be able to speak with you one-on-one, a real person who's waiting to talk to you and support you. So again, if we missed your registration question, or if you have anything that you'd like to follow up on, please reach out to our MDA team. And that will be at 1-833-ASK-MDA1, or you can email us at resourcecenter@mdausa.org. If you'd like to get in touch with the community education team specifically, you can also ask for that, and we will be happy to speak with you. So again, I want to thank Dr. Thornburg for sharing her time and her wonderful expertise today. This was such a wonderful topic and such a wonderful time to spend with you all. And before you go, we do want to hear from you. What did you like about our program today, or what can we do better in the future? Please fill out the brief survey that will pop up right after the webinar. I assure you we look through every single one, and that feedback is so important as we plan future programs. And again, if you have any questions or looking for more support today, please contact our resource center, and we are happy to speak with you. This will conclude today's webinar. I hope everyone has a nice week, and we will see you on the next one. Bye.